Good afternoon, everybody, and welcome to the Health and Wellbeing Board. My name's Councillor Cathy Scott. We do be having a bit of an IT problem, so just bear with us. So, as I said, good afternoon. Welcome to the Health and Wellbeing Board. My name's Councillor Cathy Scott, and I'll be chairing the meeting today. It's just to let you know this is only an interim appointment until it's ratified in Council who will be the chair of the Health and Wellbeing Board. So we'll move on to item 2 of the agenda, and it's membership of the board. Are there any apologies today?
Yes, Chair. We've received apologies from Councillor Carol Patterson, Councillor Mark Thompson, Tom Brailsford, Vanessa Taylor, Dr Warren Gillibrand, Alistair Brown, Chief Superintendent Jim Griffiths, Christine Fox. That's it, Chair.
Thank you. And if there are any subs that are in attendance for any other members for this committee, are you able to identify yourself now or ensure that the officer has that on the paperwork before you leave the chamber today? Yes. Okay. So we're going on to item 3 on the agenda, minutes of the previous meeting. Can I take them as a true and accurate record? I take that as an indication you're all in favour. Thank you. Just for noting today, there is no decision to be made today. There will be presentations and discussions and feedback at all times, so there is no decision making today. If you have any declarations of interest on item 4, please ensure that you give them to the officer before you leave the chamber. Also, admission of the public. There's no items to be taken in private, I take it. Are there any deputations or petitions?
None received.
Thank you. So we're going on to item number 7, the appointment of a deputy chair. So the board needs to appoint a deputy chair for the municipal years for 24-25, and I'm proposing today Warren Gillibrand. Are there any other proposals? Are we all in favour of that? That's carried. So we're moving on to item 8 on the agenda, Kirklees Safeguarding Adults Board Annual Report, and it's Jackie Stanfield that will be delivering this report today. So, I do believe Jackie's online, and I will mention that we do have another member that is also joining us online, James Cregan. He's on annual leave, but he's actually coming online as well. So over to you, Jackie.
Hi everyone. So I'm here to present the annual report for the Kirklees Safeguarding Adults Board on behalf of Rob McCulloch Graham, who unfortunately is not being able to attend last minute. So let me just bring the PowerPoint presentation up. Apologies, I did have it ready, but you can do it online now, so it's a bit trickier. Take me 2 seconds, 1 second. So you should be able to see that on screen now. One of the duties of the board is to produce an annual report. So the purpose of today is for information and awareness, and hopefully it'll demonstrate how we work together across the partnership to deliver our strategic objectives. So the annual report's from 22-23. And it's our vision and role of a board. So safeguarding adult means stopping or preventing abuse or neglect with adults who have care and support needs. So these are people under the Care Act. The Care Act care needs are caused by physical or mental impairment or illness. It's the job of the board to make sure that there are arrangements in Kirklees that work well to protect adults with care and support needs from abuse or neglect. So we do that by assuring ourselves that the local safeguarding arrangements are in place as defined by the Care Act 2014 and the statutory guidance. We assure ourselves that the safeguarding practice is person-centred and outcome-focused. We work collaboratively to prevent abuse and neglect, and ensure agencies and individuals give timely and proportionate responses when dealing with these cases. And we assure ourselves the safeguarding practice is continuously improving and enhancing the quality of life of adults within the Kirklees area. So this is just a slide on the board structure. So we have the independent chair, the different sub groups underneath that all feed through the strategic delivery group up to board. These are the different work groups that help deliver the strategic objectives. So our vision is to work together to take action to keep the people of Kirklees safe from abuse and neglect. So we do that by putting people at the heart of everything we do. We follow the 6 safeguarding principles, and we work together providing leadership, protection. We look at prevention, learning and seeking assurance across the partnership. So throughout the year, one of our objectives was supporting the workforce. So in 22-23, we worked with our regional consortium colleagues and procured an online platform which has the overarching aim of enabling our joint multi-agency safeguarding adults policy and procedure to be easily accessed by partner organisations in West Yorkshire, North Yorkshire and City and York. So for those that actually work across different boroughs, it's the same policy and procedure. So, and it can be accessible on mobile phones when people are out and about easily. The platform provides practical support with a range of tools and guidance which have been tried and tested by practitioners, and has a dedicated area which can be populated with local safeguarding contacts and resources. So for example, any network events that we do that people haven't been able to attend, we can put on that platform for people to view at their leisure. So we did several network events in that time where we invited frontline staff and volunteers. The Dignity and Care Steering Group organised an event to raise awareness around the NHS Civility and Respect campaign and how we could adapt and adopt that to improve practices for staff and volunteers across the safeguarding arena. It focused on the impact of low-level behaviours on people and professionals working with them. So what it meant for people, it made people more aware of how their words, even if it's unintentional, can affect others. It was around rudeness being perceived by the hearer rather than the intended speaker. So people said that they found it really thought-provoking and really thought about their own actions. The Safeguarding Adult Review subgroup do a network event every year, and we looked at how we could learn from cases where people experience serious harm or death. So that is unfortunate when someone suffered serious harm as abuse or neglect or have sadly died. The second network event we followed up again around practitioners, and we continuously take the feedback from those events to shape how we move forward into the next planning cycle. So another shared objective is learning from experience. So we continually look at how we deliver effective and professional services across Kirklees, putting people at the centre and draw on the experiences from a variety of partners involved. We take an agile approach, reacting appropriately to the ever-changing landscape, and this is national, regional and local, using experiences to continuously learn and improve service delivery. We look at good practice and any challenges that could be improved, and we share this through the board subgroups. And in board meetings, we re-evaluate and improve, look at how we can improve across the partnership, reviewing and amending current policies and procedures reflective of the feedback from practitioners and people with shared lived experience. Partnership working obviously is something the board really pushes, and we continuously to be proactively working towards building a communication friendly culture, learning from each other and seeking out different ways of sharing information. We look at how we can expand on the current networks to help us find solutions to challenges that we face. We will continue to strengthen links and work closely with the other boards, so that's the Community Safety Partnership and Children's Safeguarding Partnership. And we look at safeguarding strategies which are effective, looking at self-assessment and joint learning events. We continue to strengthen and develop collaboration with our wider partnership boards and build on the existing methods for sharing and embedding learning from reviews and lessons. So we look at community and public engagement, promoting the development and expansion of stronger networks to gain insight of the effectiveness of safeguarding arrangements. The first step to build local capacity through the partnership is to identify shared priorities for the community, and by linking in people who live and breathe what's going on in Kirklees, we can gather the right level of demographic around economic and related social issues. Safeguarding Week, which we are currently in this year, brings a great opportunity to do this. So as we're seeking insurance, one of the things the board does is a challenge event. This is led by Rob as the independent chair, and we invite Health Watch colleagues and people to help support with that. And that's where we do constructive challenge around the performance over the previous year for the different partners across Kirklees and agree some of the priority areas moving forward. So the main points for the board moving forward from 22 was reflecting on the past and looking to the future and minding the gaps, so where people maybe fall through services and communication, always looking at improving on that, the joint working, building relationships and information sharing. So looking ahead to 23-24, we was looking at building on the success of that year, and the board will continue to work together with partners across the partnership following the 6 principles. So that's the presentation, open for questions.
Thank you for that, Jackie. So I take it by the silence you're all happy with that. Okay, so that's noted. Thanks for your time on that, Jackie, and all the efforts on that. Thank you. So
No problem, thanks.
So we're moving on to item 9, the Director of Public Health Annual Report 23-24, Inequalities in the Experience of Death and Dying. Rachel Spencer-Henshaw will deliver this. This is also for discussion after.
Thank you so much, Chair. Thank you, everyone, for letting us bring this report here today. Even though obviously this report is in my name, I'm not going to say a lot because there's colleagues here that have done a huge amount of work in pulling this together. I just want to say how important the work has been to work alongside the Kirkwood Hospice, who've been a fantastic ally with this project, and we really hope it's going to change things for our population going forward. So, have we got some slides? Are they coming up? Oh, am I running them? Sorry. I've got them actually. So, oh no, it's not those ones. There's a lot of slide sets today. First one. That's it. That's it. So if you just go to slide 2 for me, Matthew, that would be great. Okay, so obviously for the Health and Wellbeing Board, we've brought annual reports every year. And it's a real opportunity, I think, as a system to look at how we can use these to inform what we do going forward. It'd be really helpful to get any of your feedback on how we can take the report further, because obviously this is just the start of what we hope will be multiple conversations, as we did with previous reports. And what the team will do is talk to you about what they've done, what they've found, and what they think the key recommendations are. So I just want to thank everyone who's contributed to this, because it is a fantastic piece of work. I'm going to pass over now to Lucy.
Thanks, Rachel. So I'm Lucy, Head of Improving Population Health. I work in public health. So next slide, please. Thank you. So just to explain to you the purpose of Rachel's report. So this is Rachel's independent annual report. It's up to the Director of Public Health what they choose to focus on with the report. And this year, the focus is on death and dying. We're really clear that we want to use this report as a vehicle to identify important key issues and gaps, flag up problems and report progress. And if you remember the DPH report from last year, which was on poverty, that has enabled us to take conversations about poverty into areas and organisations that we wouldn't have before. So even though it's obviously Rachel's report, we're really seeing this as something that we want to be used across the system. It's also a key resource to inform stakeholders of priorities and recommend actions to improve and protect the health of the communities they serve. I think the other important thing to say about the report, which we've tried really hard to do, is that we want it to be as accessible as possible for people to be able to read and access. So it will be hosted on our Kirklees Council website, and it's in chapters, so people can dip in and out of it as they wish, rather than reading it from beginning to end. Sometimes DPH reports can be incredibly academic or long. I'm not saying that ours isn't long, but we've tried to make it as accessible as possible for people to use. Next slide, please. So as I've already said, the focus for this year is on the inequalities and the experience of death and dying, as well as trying to take an asset-based approach and understanding what assets and opportunities there are within local communities across Kirklees, recognising the differences there are between population groups in different places across Kirklees. The thing that we were conscious of when we started this work is that there is already a lot of work already happening within this space. So you'll be aware of the Dying Well board that is in place. And also there's been recent insight gathered by Kirklees and West Yorkshire Health Watch teams. So what we wanted to do was add value to what has already happened rather than repeating works. That the thing that we wanted to focus on was around the understanding of inequalities. So we know that there's obviously lots of things we can do universally with people to support a good death, but we also know that there's significant inequalities across different population groups. So we really wanted to explore that in the report. Next slide, please. So in relation to that, we looked at national evidence in order to help us to understand which population groups are most at risk of experiencing inequalities and death and dying. And those are people who identify as LGBTQ+, people experiencing homelessness, people with learning disabilities, people with non-cancerous health conditions, people with serious mental illness or addiction issues, people living in poverty or deprivation, diverse experiences by race, ethnicity or faith, and unpaid carers. Next slide, please.
So what we asked, we asked a series of questions to a range of groups across the district. We sought to kind of work with the organisations largely rather than the kind of individuals because we felt that had been sort of captured already. However, I suppose it's not really surprising that actually through that there was also kind of various sort of personal stories that sort of came to light as well through that, which we've sort of tried to capture as much as we can. So we tried to keep it quite simple. We sort of just set about sort of like 4 sort of main areas. One around the kind of experience of end-of-life care and planning in Kirklees and their experience of that, or the experience of their service users. with trying as much as possible to maintain that particular emphasis on inequalities, and specifically in relation to the group that we were talking about at that time, obviously appreciating that those are not mutually exclusive and there's sort of like crossover you know, at times as well. Thinking as well about the gaps and the challenges that people might have identified, specifically trying to draw out kind of specific examples that we might be able to sort of use within the report. And also obviously local strengths. There's a lot of really, really good work happening locally across the system, and we really wanted to capture that as well. We didn't just want to sort of like focus on sort of what else we need to do, but what we are doing and how we can kind of celebrate that as well. And finally, we just asked people quite a generic question around what would help them to improve, to have an improved experience. So quite broad questions. Just obviously the sort of we were sort of flexible in the way that people wanted to sort of have those discussions. Sometimes they were sort of larger groups. Sometimes they were one-to-ones. But we did manage to speak to quite a good range of people across the district. Next slide, please. So here's just a couple of examples of things that we heard. The top one, I think, especially is quite powerful. Often end-of-life planning is not actually a priority. People struggle to make it a priority, and there are other things in their lives which are still more important. If you're homeless, or you've got multiple complex needs, or you're struggling with significant poverty, then dying is not top of your list. And then the second one as well. So you'll see a lot of people praying quietly. Sometimes I think hospital settings, doctors, nurses can get overwhelmed by how many people are visiting this person. But actually that's part of our culture and our faith, and being able to pray for the person who's dying. There are lots and lots of stories and extracts, some of which as many as possible, we've tried to capture in the report. But that's just a couple of examples for today. Next slide, please. So we've put together an animation. This is sort of based on feedback from last year, and there was an animation that was really, really well received. So we thought we'd do something sort of similar again. Again, just to sort of make it accessible for people and to sort of summarise what we've done and what the main findings were in a way that hopefully a broad range of people will be able to sort of digest in quite an easy way. So are we going to play that now, if possible?
Over 3,800 people in Kirklees die every year. For many of these people, death is a gradual process which happens over days, weeks, months or years. In these cases, dying is a developing part of life that may lead to financial pressure and increasing contact with health and social care. We all want a good death for ourselves and our loved ones. However we choose to define it, this means receiving the right support in the right place at the right time, enabling us to meet our physical, emotional and spiritual needs. Unfortunately, some groups of people are less likely to have a good death. This report explores the reasons behind these differences and suggests ways we can reduce these inequalities. Building on existing evidence, we spoke directly to local organisations. This enabled us to gain a more rounded understanding of the inequalities experienced in death and dying in Kirklees. We spoke to local organisations who work with the LGBTQ+ community, people experiencing homelessness, people with learning disabilities, people with non-cancer health conditions, those experiencing mental illness or addiction issues, those living in poverty or deprivation, people with diverse experiences by race, ethnicity or faith, and unpaid carers. Every conversation gave us a new perspective, helping to shape our recommendations. Common themes included staff training and awareness, service-related information for patients and their loved ones, death as a taboo subject and avoiding difficult conversations, being sensitive to individual needs, circumstances and choices, access to and linking between services and support. The full report includes detailed insights from each inequality group. So, what does this mean for us? To reduce inequalities in death and dying, we should encourage conversations within families and between healthcare professionals and patients about managing and living with a life-limiting condition and about death. By understanding people's wishes, we can help them put plans in place and focus on what matters most to them. Educate staff how to have death-positive conversations and be culturally sensitive, to raise awareness of options among patients, carers, relatives and colleagues. Engage with palliative and hospice care across services to support those with a life-limiting illness from the point of diagnosis. This essential aspect of healthcare supports quality of life and a good death for everyone in every place. Enable people to make decisions that suit their individual needs. A person-centred approach and develop improved support mechanisms. Expand on support currently provided by services and build on existing community assets. Evolve services as the population changes and involve communities in the decision process to ensure inclusivity. Delivering better palliative and end-of-life care will have a positive impact on every part of our health and care system. Embrace the findings in this report and other evidence. Share with colleagues. Keep talking about death and dying. Take steps in your personal life to ensure you and your loved ones are better prepared. As a system, it is now our job to take forward these recommendations, to enable every person in Kirklees to access and receive good quality end-of-life care and planning when they need it. Thank you to everyone who contributed to this report via discussion group sessions. The report would not have been possible without your valuable input.
Good, thank you. So the animation that you've just watched summarises the key points from the report. There's a lot of information and insight that we gathered as part of the process. And as Lucy alluded to earlier, what we wanted to do was to make sure it was accessible as possible in the way that we present it. So the animation is one example of that. We've got a couple of screenshots here as well of how the report looks on the website. So it's broken down into smaller sections to make it easier to navigate to particular sections if you've got a particular interest. We also tried not to overload it with too much data so that it's not, there's not too many numbers in there, but we just brought out a few key facts around death and dying in Kirklees. And we've also got a PDF exec summary and a plain English summary as well, so that people can read it that way if they want to. Next slide, please. One of the important parts of the report are the case studies that we gathered. So we've got a few case studies just to highlight some of the good work that's going on in Kirklees already. And hopefully by sharing these examples, we can demonstrate best practice and encourage others to adopt those methods. We've got case studies from the Mission in Huddersfield, a few case studies from the Kirkwood, Kirklees Libraries as well and the work that they're doing. And Change Grow Live as well, who are our commissioned drug and alcohol service provider. Next slide, please. And it's not just about the local picture as well. We're obviously operating as part of a bigger system and the national recommendations that we've incorporated into the report. One of them is there was an all-party parliamentary group on hospice and end-of-life care that's had a debate in Parliament recently around palliative care funding. There's also the Marmot Review that came out a few years ago now, but it's got some important points to make around healthy standard of living and how that applies, or how we could apply that through a lens of death and dying. And there's also nice guidance as well on end-of-life care and care at the very end of life, the last few days. Next slide, please. And what we've also tried to do, as well as some system recommendations, we've also tried to incorporate things that individuals could possibly do for themselves, aware that not everybody would be able to do these things, but we've got a list of potential things that people could consider, things like making a will, and getting their financial arrangements in order. These are things that people could do well in advance of knowing that they're approaching end of life. Planning for future care, organ donation, thinking about your digital legacy, so what happens to all your online information after you're gone. And then making sure this is all documented, and making sure that your loved ones know what your preferences and wishes are, and also ask them to share theirs with you too. And using things like the Tell Us Once service if you need to report a death, which helps to join up services and makes things as easy as possible. Also highlight on this slide the cost of living support page on the council's website if people are struggling financially to do those things. Next slide, please.
Okay, so in terms of next steps, the report is it's there, we're there, so it's going to be published hopefully this week or next, and obviously we'll share it with the board once that's happened. We'll also take a dedicated session to present and discuss with the Dying Well Board, where we're hoping that we can have some of the more operational discussions about how we move the recommendations in the report into action across Kirklees organisations. And then there's also a project team who will be disseminating the report across a broad range of local organisations. I think the thing that we really want to do, though, is not to see it as like being owned by public health. So last year and this year as well, we'll have a presentation that can be used by anybody. So if you want to share the presentation within your own organisations, then obviously that would be very welcome. Next slide, please. So finally, it's really over to board, questions for board. So the first question is, how can Health and Wellbeing Board disseminate and support the findings of this report? And also, if you could discuss what are the opportunities for joint work across the system, and obviously any other broad feedback that you have as well would be really helpful. Thank you.
Okay, thank you, Lucy and the team. That's an exceptional report. I had the luck of seeing it earlier this week, so it's a really, really good report. I do note that Michael Crowther is here from Kirkwood Hospice, and is there any comments or that you want to contribute towards this discussion?
Thank you, Chair. Just to say, as an organisation, we were delighted to be involved in the development of the report and to help steer some of this work. So that was really important to us. I think again, it's really important to us that this report and the leadership around this reinforces it as a priority for local people and the system. So it kind of puts this squarely in amongst the priorities. It's good that the report recognises a good practice that that exists in Kirklees that we can be proud of. But it also identifies some gaps, and in particular, those gaps are exacerbated where people are already experiencing inequalities. So I think that the report really usefully shines a light on that. But it moves into things that can help, and I think one of the things is about building on what good looks like, because there is evidence that actually people of all identities can experience a good death if the the services are accessed and the conversations happening at the right time. So we're really supportive of the recommendations, in particular about keeping this front and centre in the view for the system, and encouraging the right conversations at every level about just how important this is as an outcome for individuals, for communities and for the system. So yes, just thank you to the team for involving us.
Thank you, Mr. Crowther. Could I bring in Carol McKenna?
Thank you. Is it okay just to ask a general question? I don't really know who I'm directing it at, Rachel, if it's you or if it's your colleagues, but thank you for that. I look forward to reading the full report. It looks really interesting and really timely, I think. Just a general comment, there's been a couple of references to the Dying Well Programme Board already, and the Health and Care Partnership, or the SEB Place Committee. We received an update from the Dying Well Programme Board back at our meeting in April, I think it was, which was really thought-provoking, really valuable, and I think it's helpful to see some of these issues now being talked about through the Health and Wellbeing Board as well. I think that I had a couple of specific questions which people may or may not be able to answer, but just it provoked a couple of thoughts. I seem to remember, and Michael, it might have been you that shared this previously and I can't remember, but I think we have got information in Kirklees that demonstrated we were making improvements when it came to people being able to die in the place of their choice. And I think the only reason I mention that is because it's that point about building on the good work already there and recognising that we have done quite a lot in this space already, but that clearly there's loads more to do. The other bit was that I'm just quite interested in was the issue of bereavement support. So when you look at the groups and individuals that were mentioned there, and those groups that experience inequalities or are less likely to experience a good death, I'm just interested to know how that plays through into conversations with the families of the bereaved and what that means for bereavement support, which may potentially be a bit more specialist than, I don't think the right word is normal, but more standardised bereavement support. So I didn't know whether it had extended into that arena as well in the conversations that you'd had.
I couldn't hear the beginning of your question, Carol. Was it around support for families as well?
Yeah, it was the families connected to those individuals in the groups identified as experiencing inequality.
Yeah, no, that's definitely within the report, and we're seeing the death not just as ending at death, but the ripples that are felt after the death as well in terms of support which people need, and I suppose what came out quite strongly in the conversations that we had with people, with organisations, was that often the trauma that is left behind from a death which hasn't been planned for or is traumatic, and the specific support which is needed. So I think that would definitely be something which would need to continue through the Dying Well board, and understanding death in that holistic perspective, not just about the individual.
Thank you, Lucy. Any further questions? No? Rachel Spencer-Henshaw.
Thank you. I just wanted to also highlight for particularly health colleagues and social care colleagues that there is some very strong evidence around hospice care, that if hospices get involved with people earlier, for potentially people in care homes or people in secondary care, then we know that we can prevent things like unwanted admissions to hospital, for example. And if we can work with primary care to get them to be a lot more proactive about referring into hospice support earlier, when we've got that diagnosis, what we will end up seeing is potentially a better impact on the system in terms of demand. And obviously this report is more about the kind of compassion, etc. But in terms of how we actually, as a system, benefit from this as well, there's definitely an investment, a business case there about making sure we involve those organisations a lot earlier and in the settings, not just in the hospice itself. It's very much based on the outreach model that the Kirkwood particularly have done a fantastic job in doing. So I just wanted to mention that because it's very easy sometimes to forget that actually there is a real business case to this as well.
Thank you, Rachel. Are there any further comments? Dr. Naheem.
Thanks very much. I would think that Kirkwood Hospice is doing a wonderful job, and I can see a lot of our patients benefiting from the Kirkwood Hospice community outreach service. I think what our experience is that people whose loved ones are going to die before and after death, they appreciate single point of contact where they can contact somebody for advice on different things, because there's a lot of confusion sometimes in the system, whom to contact for what, for example, anticipatory medication, how to make patient comfortable, and with the changes coming in the reporting of medical cause for death with ME surveys and and the new MCCDs going to be introduced from September onward. The delays in reporting some of these, the issuing of MCCDs because of ME with certain communities, worried about some delays. There is a lot of work going on at the Kirklees, but mostly at the West Yorkshire level, where some of these delays are, the ways are, we are trying to find ways of mitigating some of these delays, especially out of hours and weekends. And I think we need to see how we can work collaboratively to ensure that services go on smoothly, and people whose loved ones are end of life, they are aware of all the services there, and they know whom to contact for what. So I think that's something which would definitely help.
Thank you, Lucy. Do you want to respond?
Thank you very much. What you said was also reflected in the conversations that we had, and I suppose one of the points of this report is that it's provoking these discussions so that we can then feed that into the work of the Dying Well Board and look at that. But I don't know if only you had anything you wanted to say more specifically about that point around the... No. I'm scared to touch the point. Okay, thank you.
Okay, so there's no further questions. Thank you for the work. Sorry.
Sorry, I'm going to be brave with the mic. I just wanted to highlight in response to Nadim's comment there that community champions are about to move on to an end-of-life topic. So I think, that's another way of having those conversations with people in our communities to help inform them of what support and the range of things that are available, that people may not realise the breadth of what is there and who can support. Thanks.
Thank you for that. So we'll now move on to the next item, item number 10, Health and Wellbeing Strategy Priorities for Mental Wellbeing, and that will be Rebecca Elliott.
Do we have the slides, please?
Thank you. Can you hear me okay? Lovely. Thank you, everybody. My name's Becky Elliott. I'm a Public Health Manager at Kirklees Council, and we're here today to give an update on the mental wellbeing priority of the Health and Wellbeing Strategy, but with a particular focus around the trauma-informed approaches that we're trying to take across Kirklees system. So that's the deep dive that we're having a discussion on today. So we're really, really pleased to be here. Next slide, please. So we're really pleased to have some fantastic speakers with us today from different organisations across Kirklees Place. That's why there's so many of us here. We're going to be sharing some fantastic examples of trauma-informed approaches that are already happening across our place. We know that trauma is a public health issue. Research tells us that people that experience adverse childhood experiences, we know, are more likely to use alcohol, smoke, develop chronic diseases. And of course, trauma can happen at any time during the life course, so it's really important that we think about trauma-informed approaches across the full life course. People are also more likely to develop mental health conditions, so it's really important that we all consider and think about how trauma-informed our organisations are and also how trauma-responsive they are, not just for the population that we serve, but also for the workforce that we employ. So we really welcome the opportunity to be here today to work with you to develop strategic support for trauma-informed system change. Next slide, please. So this is the pledge that our Director of Public Health, Rachel Spencer-Henshaw, agreed last year when we first embarked upon this journey to become a trauma-informed organisation as a council by 2030. So as you can see here, there's some references to tackling health inequalities across the life course and thinking about working really at place level within our communities to understand how we can build upon the local assets that we have across Kirklees and enhance those protective factors for resilience. So we really are at the planning and preparation stage of our trauma-informed journey. And then next slide, please. So I'd like to introduce Em Irving, Head of Improving Population Health from West Yorkshire ICB.
Okay, I think I've worked this right. Hi, thanks for having me. So I'm just going to give you a quick overview of the West Yorkshire programme that supports the programmes that are happening in place. So if you can move on to the next slide, that would be great. We always start a bit doom and gloom. We are a world teetering on the edge of a cliff. We've got all sorts going on that's causing trauma and adversity for our population. And instead of talking about what we could do, I talk about what happens if we do nothing. Because if we do nothing, we're going to see the increase of children born into poverty. We're going to see an increase of children and adults in our criminal justice system. We're going to see an increase of violence, of health harming behaviours and disease. So we've got to act, we've got to do something. So I lead the programme across West Yorkshire, if you want to move on to the next slide, please, that looks at how we can work together as a system, all organisations, the entire workforce and our population to be trauma-informed. It's an iterative journey, it doesn't end, but there is a point where right now we would say we're not trauma-informed and we're not overly responsive in many of our services, even though we've got some amazing good practice. And what we want to be is in a position where we can say we are trauma-informed and we are responding, but we're also constantly learning and building on that journey. So the West Yorkshire programme is around supporting capacity, capability and intelligence across the system, including place, providing resource, providing training and expertise around the subject area, but also working with the large West Yorkshire organisations like West Yorkshire Police, the acute trusts and the Integrated Care Board itself to become trauma-informed. And then we provide the support down to place for how you enact this in Kirklees and become a trauma-informed and responsive place. So we've got programmes in every place, all at different stages, that are undertaking a maturity matrix at the moment. And I don't know if there is another slide, there could be. And that maturity matrix, there we go, is going to tell us where we all are in our journey and how we can start to work together. But more importantly, how we can change the narrative from West Yorkshire sort of driving to place driving and West Yorkshire being there as that supportive mechanism and arm. So I think that's it. I think I've stayed in my 5 minutes.
Yeah.
Cool.
Next slide, please. Thank you, Em. So now introduce Alistair, Joe and Tom. I think Al's doing the speaking on behalf of the Blossom Service at Calderdale and Huddersfield Foundation Trust.
Hi, if we could just move on to the next slide, please. Sorry. So yeah, nice to meet everyone. My name's Alistair. I'm service lead for Blossom at CHFT, which is our multi-agency support team that we've established across both of our emergency departments in Huddersfield and Calderdale. So our funding has come from and we're really proud to be part of the ATR network. And myself recently completed a fellowship which was run by the ATR. So our service has introduced youth navigators into our emergency departments to proactively identify and engage with young people who may be at risk of exploitation, criminal activity, or involved in serious violence. It's based on navigator services which have run across the country, but what we have really focused on at CHFT is young people who have history of trauma and ensuring that we can identify and support those young people appropriately and make those onward referrals into community services. We've also got a real focus on reducing those reattendances back into the emergency department by meeting that unmet need of young people that we're supporting. So we're following on from Leeds and Bradford, who were the pilot sites in West Yorkshire. But what we've done is really try to focus on the needs of young people in Huddersfield and Calderdale especially, and kind of build our service around what young people need. Another priority that we've had is how we integrate the principles of trauma-informed practice to our clinical staff. And for the last 2 years, we've delivered a module on trauma-informed practice to all ED nursing staff And from next month, we will also be delivering that to our clinicians across ED as well. And we've already seen a difference in the kind of culture within our departments and how staff are recognising people attending who have had previous trauma and how we respond to that. And I feel like as a department, we've definitely grown in that period of time. If we could just nip on to the next slide. So the challenges that we have are that we're not a permanently funded service at the minute. We want to grow, we want to develop our service. We've recently worked closely with CGL and Recovery Steps, and we've now introduced a recovery navigator into our team. We want to look at that all age, we want to introduce that and how we support people of all ages, not just young people. And we're looking at ways that we can do that. We can do more with less. And building those relationships and those networks have been really helpful in those terms. A lot of times people ask what trauma-informed care means to us and what it looks like in our department. And I just want to, before I finish, quickly share a story from last week. So what our youth workers saw a young person who'd attended ED with a laceration and been brought in by ambulance staff. So that young person had seen paramedics, a triage nurse and clinical staff. But it wasn't until the youth workers went in and built that relationship and created that open environment that the young person actually disclosed that they'd been stabbed, they'd been involved in a stabbing, and from that we were able to alert the police, able to alert children's social care, and it's just kind of how do we create that environment where people are more willing to kind of share their story and open up and create that trusting environment. So yeah, I think that's pretty much us, the Blossom team.
Thank you, Al. Next slide, please. So if I could introduce Katerina Westwood from South West Yorkshire Foundation Trust.
Hi, good afternoon. Thank you. I'll just give a project summary. So we use a change management approach within SWIFT to become a trauma-informed organisation, which was endorsed by our executive management team September 2022. And this has been involved working with experts by experiences. We are currently on phase 3 of our programme, which I guess is moving into year 3, where SWIFT continues the journey to become trauma-informed organisation, and it's about underpinning everything we do. So the core principles of trauma-informed have been adopted within our strategic objectives in our priority programmes as well across our trust. Thanks. Next slide, please. So phase 3 of the programme is we've got quite a large focus on supporting sustainable changes as well, and changes to behaviour in practice, and by continuing the operationalisation of the framework and enabling it to be a golden thread. So as an organisation, we're weaving it through everything we do, baking it into everything we do. The core principles are being trauma-informed as well. And there will be a natural wide emphasis on staff support and wellbeing, and thinking about trauma-informed principles with the self and our trust recruitment and retention of staff as well. Some of our great successes has been actually, and this was in the early stages of the programme, about the co-designing and co-delivering of our trauma-informed awareness training, particularly in terms of the culture shift and actually speaking out to his staffing groups about the trauma-informed principles and getting staff to reflect and actually have that embedded within the everyday practice as well. And that's not just for the populations and people who we look after and care for, but actually for ourselves as employees, for trust. We've actually delivered train the trainer sessions now, because we are a large organisation that covers obviously a huge footprint, and it's about us all owning this and actually embedding it in everything we do as well. We've successfully rolled out an extensive programme of community of practice, which are held every month for an hour, and this has got quite a large attendance from everyone across the organisation, where actually we get people to come to speak about their successes and how they've embedded being trauma-informed, and in particular about looking at that message that actually it's everyone's business and we're all human, and it's not just a standalone objective we want to achieve, it's actually everything we should be doing and breathing. Being trauma-informed, again, it's a big identified need it's about being recovery focused, and again, huge emphasis that it runs throughout all our priority programmes as well. Current challenges, I guess, with anything is just thinking about resources and having that insufficient time and staff to embed embed it within timescales as well. But again, it's an ever-evolving journey as well, and we're linking very closely with Emmeline and her programme as well. So some up-and-coming milestones, we are delivering our trauma-informed awareness training to our Trust Board, and we have got our Trust Board and members who endorse this programme as well. We're launching this mandatory learning package September this year. We have launched the face-to-face training as well, because we do acknowledge that it may be quite a sensitive subject as well, and that staff might naturally want to attend the training face-to-face, so it's thinking about the well-being of everyone as well. And again, just to reinforce about building in trauma-informed within our health and wellbeing and support for staff. And what we continue to do is when our policies, our trust policies are being renewed and updated, we actually look at those through a trauma-informed lens. So they're naturally, as time progresses, will have a trauma-informed lens throughout them as well. Thanks.
Thank you, Katerina. Next slide, please. I'd like to introduce Louise Seddon, who is here representing the Council and Locala today. Thank you.
Thank you. Good afternoon. My name's Louise Seddon. I'm here to represent Locala. I am a nurse specialist with the Youth Justice Service, and I have a special interest in trauma-informed care. We understand what the research shows us about adverse childhood experiences, and as Rachel has said, the impact that has across the life course. We see this on the front line of care. There are children and families who are living in increasing poverty, facing increasing community tensions, and increasingly facing the violence within their communities and the exploitation that a lot of our children and families are faced with at this moment in time. And with that, we have to consider the need for a trauma-informed care approach, and that needs to run through the whole of our organisation. It's multifaceted, and our vision focuses upon considering the needs of both the client base and our staff. We understand that trauma is something we consider through the life course, from the start of somebody's life at conception to the very end of the life. And with our approach, it's considering the voice of all our clients, their lived experiences, and listening with care and compassion, and providing our staff with the skills to provide trauma-informed care. It's considering the client and patient's experience from the minute they might enter a health centre, so it's considering the training needs of all our staff, and we consider training from the bottom to the top and the top down, so we need buy-in from our chief executives to endorse our trauma-informed policy, but we need to consider co-production, and we need to consider that with our client base as well, because we have a wealth of experience and people within our community who would want to share their experiences to move forward, to make positive change for children and families moving forwards. It is about having visionaries within our organisation who are willing to drive trauma-informed care, and it's about taking our staff on that journey and embedding that within our practice, and making it something that it's a non-negotiable, it's something that we have to buy into, and that's with training and the support from our leadership team. Successes, we have already started to deliver some training around adversity and trauma-informed care. We have support from the executive structure, and we're working towards a culture, as I've said, of embedding that within our workforce. We're invested in listening, co-production, and the delivery of services that deliver trauma-informed care, and it's about working with people and taking them on that journey rather than doing to somebody. current challenges, we're still working towards developing full-time posts which will focus upon this trauma-informed journey. Training provision is limited due to capacity within our workforce, and organisational changes, lack of coordination and lack of funding for services.
Thank you, Louise. Next slide, please. And the next slide again, please. And so I think the final update is from Mary and Jane from the Council.
Thank you. Good afternoon, everybody. My name is Mary White. I'm a Commissioning and Partnerships Manager within Children's Services in the Council, and I'm here to talk about a couple of the services that colleagues of mine across Children's Services have been delivering. I'll talk a bit about the Educational Psychology Service first, who had some funding through the Alex Timpson programme back in 2018 to begin to develop a programme of supporting schools around behavioural problems, and adopted a trauma-informed approach to do with that. And as a result of that bit of pump priming funding initially, we've been able to develop a whole school programme so we can support schools to look at their own planning, look at their own school populations, look at the wider community issues that they're encountering and the services that sit around them, and how they can support children in a trauma-informed way. And that's been really important for a number of our schools' behavioural policies, actually, to sort of work with children to ask what's happened to you, what's going on in your life, rather than what's wrong with you, why are you doing this? It helps to actually get to some of the roots of the issues and to provide a more kind of person-centred and much more supportive environment for those children and young people. And that's been a really important bit of pilot funding that's enabled us to use that bit of deep learning and to grow that programme across schools in our new Kirklees Keep in Mind mental health support model. One of the challenges around that is around sustaining that with funding, but I think that's the story of the afternoon for many of us, isn't it? I'll hand over to Jane to tell us a bit about what's happening in employee healthcare, and then we'll come back to me.
Thank you. Could we have the next slide, please? Good afternoon. I'm Jane Healy. I manage the Kirklees Council's Occupational Health and Wellbeing unit, and just I'd like to share some successes of that unit. So we've developed a neurodiversity pathway. So as an inclusive employer, we like our staff to be themselves and to perform to the best of their abilities. So we've been working a lot around supporting people with a neurodiverse condition. And for the work that we've been doing, we've been recognised by the Society of Occupational Medicine. Stress referral pathway, which we're proud of. So we've moved away from the traditional occupational health management referral into the unit, and we now concentrate on having wellbeing conversations and helping people to take care of themselves. Restorative practice team joined employer healthcare late 2023. And like the NHS Swartz rounds, we now have listening circles where peer-to-peer conversations go on, and we can help each other to move forward.
And back to me for the third example that we've got from work that's happening across the council. And I'd just like to point out that these are kind of snapshots of pieces of work that are happening. It isn't the entirety of what we're up to, but to give you a bit of a flavour about what's happening. Another programme that we're operating in Children's Services is a programme called New Beginnings, which is an assessment programme that we do with expectant parents where we have concerns about their children. And previously, we've had a needs-based assessment programme there. What we've begun to do now is to have a formulation approach, and that's sort of a bit of social work jargon to an extent, which is about doing a very holistic needs assessment with the parents-to-be, with the support services around them, with their wider families and neighbourhoods, to really take a trauma-informed approach to looking at what their needs are, what their support needs will be in the future, to try to, as far as possible, to keep their child safe, but also to keep that family together and think about what the most appropriate support structures are for that family as an individual, as opposed to having a template that we apply to each person in that situation. So we're coming up to our 100th case on using the New Beginnings formulation model, and it's proved to be very successful in terms of developing relationships with those young parents, in terms of those parents being able to keep their children safe and keep their children with them and family support around them. So I think that's a really useful example of how taking a trauma-informed lens to something can both lead to really positive outcomes for the children and families concerned, but also for the services who are supporting them to be able to put some intense help in earlier on, and then there'd be less demand for those services as time goes by. The challenge that we have around this, again, is around timescales, and like a lot of our work, we can develop it through pilot funding, and then the issue is about how do we embed it and how do we sustain in the longer term. Thank you. I'm going to hand back to Becky now for a summary.
Thank you. Thanks, Mary. Thanks, Jane. Next slide, please. And the next slide, please. So I won't dwell on this too much because we have touched upon some of this, but essentially we're at that stage now where we are at the planning and preparation stage of the council moving towards embarking on this journey to become a trauma-informed organisation. Mentioned earlier that we have the maturity matrix, which is essentially a tool that Mary and I are now wanting to develop some ownership for across the council, so that each service area can start taking ownership and completing this on behalf of their own service area. And that's something that we really wanted to kind of highlight today. We've been to lots of different forums and partnerships meetings, anywhere that'll have us really to talk about trauma informed. It's always very well received, and we hear time and time again pockets of really good work that's happening across the council. But what we're really struggling with is the coordination resource across the council. There isn't one person that's kind of got this as part of their main remit, if you like. So we are doing this in and amongst other work. But because we know it's so important and we are so passionate about getting this right, we do firmly believe that this is the right thing to do. So yeah, we've just put on some upcoming milestones there, and another great thing that is on the horizon that is being led at the West Yorkshire level is an organisational toolkit, which is due to be released very soon, which will really give us some kind of stages to work through to help us on this journey. So we're really looking forward to that being released as well. And then next slide, please, which I think is questions. Just a bit of time, hopefully, that we've got left for any discussion. There are 8 questions on here, but what we've done is highlight the very last one, because what we're really keen to hear about is the board's perspective on what their role could be in supporting the commitment and progression of a more joined-up way of working. So you've heard of lots of different organisations today. It's really great that we've all come together. Mary and I are looking at what we're doing as a council, but what we're also trying to do is look upwards and outwards as to what we're doing as a system as well. So you've heard of lots of examples of different training that's available in different organisations today. How can we be better at joining up on some of that resource that is available? So I'll let colleagues read through the questions, but if anybody has got anything, or if you are doing anything in your own organisation around trauma, we'd be really, really keen to connect and join up. Thank you.
Thank you, Rebecca, for that today, and also the colleagues that have also attended. So I'll open it up for any comments or discussions if there is. Can I say, because of the time limit that we have on this, what I will suggest is, if anybody has any questions or want to follow up, I'm sure they can contact you directly and fill in that information or take away the questions, because it's a bit of a big list of questions for people to ask today. So I'll open it up if anybody's interested in asking. Yes. So, gentleman here and then this. Thank you for that. So I'm going to bring in Liz.
Thank you. Thanks very much. I'm Liz Meyer. I chair the Kirklees Health and Wellbeing Partnership Committee. Brilliant to hear about all your great work. And Blossom, you've been to present at our committee, so it was good to have an update. So I think you said right at the beginning that the police are involved in this, and I was looking at particularly looking at the Blossom work in A&E with like young people maybe coming in with substance misuse and alcohol. And it would just be interesting to see how they're involved in the partnership, actually right across the partnership, because it's not just going to be with young people in A&E.
Yeah, so West Yorkshire Police are completely signed up to this, and we're just about to take a paper to the Chief Officer in partnership with the Violence Reduction Partnership, because they're key partners in the West Yorkshire programme, to look at how they become trauma-informed across the system. But we've already delivered training with all the education officers across West Yorkshire, and the Kirklees response teams have already been trained. So there's a journey still to go, but we've just employed a training coordinator who's going to support that across West Yorkshire. And every level of the police force will become trauma-informed and get that training. But what we're going to do is prioritise those services where they may well experience vicarious trauma the most, so that we can start with them.
That's brilliant, thank you.
Okay, and can I bring in Rachel Spencer-Henshaw?
Thank you, Chair. Just to say, obviously it's fabulous to see the work on the back of that commitment, and it's really, really good to see it across such a diverse amount of Kirklees services and organisations. Just to be a bit more pragmatic, because I appreciate there's a lot of questions, and I think, as the Chair said, we can take those away. But I just wonder, in order to help the board members, it'd be really good for us to be almost given sort of some kind of guide to ask the right questions, because we're all involved in a very, very a lot of meetings, I suspect, on a regular basis. And actually, language is often the issue with trauma-informed, is that people could be doing it but don't know that they're doing it in a trauma-informed way. So almost, how can we help you? And to do that, it would be helpful to get something that can guide conversations and give us a bit of a steer in terms of what to look for in some of the meetings that we're in. So that might be something to just consider, because whilst I know you're doing the assessment, which will be a big piece of work, I suspect, there is something that we can do quite quickly, I think, to ask the right questions.
Thank you, Rachel. So we have some tools and resources available already where we can respond to that. So there are language guides, I'm aware, at regional level, and we are in the process of developing a landing page on the Kirklees website as well, so that we can start having a bit of a home for this conversation. So they're the kind of things and the place where we could put some of these resources onto. I'll just check if Em's got anything to add about language.
Yeah, the language guidance is available on the West Yorkshire website with loads of other and trauma-informed co-production. But I think what's really interesting for Kirklees is that one of your previous elected members was one of our Adverse to Trauma Resilience Fellows, and she's actually prepared some documentation for elected members as well, which I think would be really useful, and she's just about to share that with Wakefield and is going to continue working with the programme. I think the other thing is that Kirklees started from probably across the partnership quite a low position in relation to what they've been doing. But Kirklees is now one of the places that's doing the most across the patch, and that's credit to the people around this table that are doing it as part of their day-to-day job. But it's come on leaps and bounds, and I just want to say that, not from a West Yorkshire perspective, thank Kirklees and colleagues for doing that.
Okay, is there any further questions or observations? No? So thank you for your time today. It's appreciated. So we now go on to item number 11, Kirklees Health and Wellbeing Strategy Priorities, Connected Care and Support. And that'll be Rachel Milson delivering. Hi, Rachel.
Can we get the next slides, please?
Hello, everybody. My name is Rachel Milson, and I work for the ICB. Our purpose in coming here today is to talk you through some of the delivery against the connected care and support priority within the health and wellbeing strategy. The paper that we submitted with papers sort of outlines the significance of the Kirklees Health and Care Partnerships Health and Care Plan in driving forward the delivery of that priority, specifically pulling out the development of the WELL programmes. So our presentation today gives you a little bit more information and draws out some of those key points around the health and care plan. And we want to talk to you a little bit more about some of the progress that we're making with those well priorities as well. And I've got some of my colleagues who are working within those programmes who are going to give you a bit more detail on those areas. So just next slide, please. So I just wanted to summarise some of the context that sits with the health and care plan. And just remind people of its purpose and how it was developed. So it's a plan that outlines how the partnerships, that's all the organisations that sit within the Health and Care Partnership who deliver sort of health and care services, will work together. So it's not just an ICB plan, it's a partnership plan to respond to regional, national and local directives. So there's not just the health and wellbeing strategy, but it also addresses some of the West Yorkshire priorities and also some of our national must-dos as well. Just to reinforce that it does support the delivery of the health and wellbeing strategy, but also some of the strategic documents that are developed for West Yorkshire alongside the West Yorkshire Delivery Plan, which is the Joint Forward Plan. We do have metrics. They are initial metrics that are within the document that was shared with papers. Just to reinforce that those metrics have been developed in the context of the outcomes framework, which supports the health and wellbeing strategy. So we were very keen to triangulate those metrics and not come up with a new outcomes framework for the plan, but make sure it really directly supports delivery of the outcomes that are within the strategy. The initial document was signed off by the ICB committee in May of last year, and when we've signed the document off, we committed that it would be a live plan. So obviously things change, things evolve, so we wanted to make sure that we reflected that, and rather than starting with a new draft of the strategy every year, we would sort of make a commitment to update and evolve the plan. And just to reinforce that the delivery is actually overseen by the Delivery Collaborative, and all the partners who work within health and care have a seat on that Delivery Collaborative as well. Next slide, please. So these are the priorities that are identified within the plan. So we've got sort of system-wide strategic priorities which cut across that life course approach, which is described in the health and wellbeing strategy, and they're the starting, living and ageing well programmes, and then Dying Well is a programme in its own right, but we've sort of represented that around the edge of the other programmes, because you can die at any point of the life course. So we wanted to make sure that although it's got its own right in terms of a programme, it's considered in each of the other programmes. And obviously mental wellbeing, you can struggle with your mental wellbeing at any point of your life course. So that cuts across as sort of a golden thread across each of the programmes. There are sort of partnership strategic priorities, and then there are some more sort of organisational level priorities that are our sort of national must-dos that we need to make sure that we focus on in the short term, and they're the priority actions which are described on that slide. And within the paper we've talked a little bit about what that means and what progress we've made in each of those areas as well. And then the sort of white box to the side, these are our sort of lenses that we want to make sure each of our priority actions and strategic priorities are considered in terms of, and these really relate back to the wider factors that are described in the health and wellbeing strategy as well. So again, just making sure we've got that link back to the strategy and that read across in terms of the delivery of that. Next slide, please. So in terms of the WELL programmes, I'm just going to introduce, and I'm going to pass on to some of my colleagues who are much more sort of well-informed in terms of the work that's happening in each of those areas. So like I've said, these are our strategic priorities. It's the place where we have the opportunity to come together as a partnership, look at health inequalities, think about how we want to plan and deliver services differently in the future, to achieve the best outcomes for people. And just in each of those boxes, there's some of the areas that each of the WELL programmes are focusing on in terms of their initial priorities and what their initial priorities will be to sort of get the relationships up and running and that work starting to progress across the system. So just pass on The next slide, please. So I'm just going to pass to Patrick, who will give you a bit more information in terms of the Starting Well programme.
Afternoon, everyone. So my name is Patrick Boozer. I'm a Transformation Programme Manager within the ICB, and I have a remit around Starting Well. So I'm just going to go through the purpose and overview of our board, our key priorities, and our next steps. So the Starting Well board has an alignment of the children and young people's priorities and the subsequent resource to deliver these. It's a single place for existing groups and boards to report to, enhancing partnership working, facilitating development of relationships, enabling connected decision making and reducing duplication across the partnership. It's a forum to discuss complicated system-wide strategic issues and opportunities, to share learning and risk. It's a single assurance mechanism to support decision-taking processes, development of a system-wide work plan, supporting groups such as the Ambition Board. It's a contact for West Yorkshire level work, for example of our integrated care system, alignment of our data and intelligence, where we'll see both qualitative information, so children and young people's voice, and then also quantitative information and numerical shared data sets. It's a partnership approach to delivering the Families Together work in absence of additional central funding from government, and it's enabling better connection of services by ensuring links at an organisational level, but also with communities. So our priorities to deliver over the next 12 months, our main focus is the delivery of the health and care plan, the Families Together implementation model across Kirklees, improvement in metrics associated with the first 1,001 days of a child's life, creation of a Starting Well strategy and work plan to bring together a range of different partner priorities, agendas and programmes of work. We're looking to integrate the children and young person's voice to strengthen representation and inclusion within our work plan, specifically looking at commissioning and strategy. And we're also there to develop a system-wide standardised metrics, focusing on outcomes and the difference made across the system. So our next steps for the board, continue with further development of the Starting Well board with a focus on strategic partnership outcomes, development of the Families Together model with a focus on 4 key sites across Kirklees, a comprehensive fixed and rotating offer of services with face-to-face availability, an online digital platform offer, universal branding and marketing materials produced and utilised by partners. The evolution of the 4 partnership boards which feed into the Starting Well board. These include the Youth Development Partnership, the Emotional Health and Wellbeing Partnership, Early Support Partnership Steering Group, and the Early Years Development Board. An action plan to be produced to support the aims and ambitions highlighted in the Kirklees Health and Care Plan. Creation of a Starting Well strategy which will bring together the 4 boards' ambitions and integrate the early help, supporting families and Family Together agendas. Support the completion of the Starting Well section within the KGSA with associated colleagues. And we've also got a presentation to the ICB committee in August to update on progress. Next slide, please. So just ask of the board. Ask number 1, to support the development or facilitate a shared platform for the Starting Well partnership to work on. One of the key issues we've had as a partnership with 10+ organisations is having an efficient and robust way to be able to share information quickly and a way to be able to work on live documentation, especially around time-limited projects. Number 2 is a resource, just making people aware of the resource which will be required to progress this work. How do we fund this as a partnership with mounting pressures? So that's starting off with the investment in Families Together, the buildings, the branding and the service provision, the development of the online platform to improve access and communication, staff time to properly resource projects, and the sharing of expertise, skills and assets. So we're talking about policy writing, marketing communication, clinical leadership across the system, our actual service provision, and then the financial resources associated with that. That's me done, thank you.
We've sort of going to touch on each of the questions and considerations at the end of each of the wells, and then we've got a sort of summary page at the end, just so we're not expecting you to answer them right now. Can we have the next slide, please? So just to introduce Jo, who's going to talk you through some of the progress we've made with the Living Well programme.
Hello, I'm Jo Hilton-Jones, a Public Health Manager in the Public Health team. I'm here representing Alison Steed today, the Senior Transformation Manager from the ICB, who is the Manager Lead for the Living Well programme, but I work closely with Alison on it. So in terms of the Living Well programme, as you can see, the context for it is the fact that we're in an ageing population, more people are living with long-term conditions, there are increased financial pressures and a real heightened need to focus on the prevention and inequalities aspects. And so, you know, in terms of that, making that shift to having a community-based prevention approach, we're focusing also on early diagnosis and that secondary prevention approach in terms of management of long-term conditions is a local priority, and how we can really focus and recognise and build on those interdependencies. And so the real driver is enabling that partnership approach to focus on better integrating our long-term conditions work and delivering those key outcomes. And in terms of aims and objectives, as you can see, there's that thread running through, focusing on prevention, early identification and that secondary prevention, the delivery of our strategic priorities and responsibilities in terms of the long-term plan and other strategic commitments. The focus of on those long-term conditions is on cardiovascular disease, including stroke, diabetes and respiratory, as many conditions that affect many of our population across Kirklees. We've talked about identifying those commonalities to reduce the risk factors and preventing onset, and also building on those programmes like the Core 20+5 initiatives to better engage and deliver our prevention approach. So in terms of where Living Well is at, we aren't as far ahead as some of the other programmes. We're not operating in a formal structure as yet. We are shaping the programme and the work streams. So we've not stopped moving on progressing work, but we haven't at this point got a senior responsible officer. And so that has been a real barrier to be able to formally establish the programme. So in terms of that kind of strategic context I've already mentioned for the real driver for progressing this work, there is the long-term plan that was published in 2019, and it talks about our commitments for the next 10 years, and one of those is about better care for in terms of major health conditions, and since that and focusing on that upstream prevention, the avoidable illness and its exacerbations, and since then there have been subsequent strategies. And we've also had our NHS annual plans that have been published that build on those initial commitments. Metrics have been introduced that we're now threading through and link back to the health and care plan, which Rachel was describing earlier. And very recently, just last year, we had the Major Conditions Strategy Strategic Framework, which was published. And so, in terms of the focus of the Living Well programme, there is that, as I mentioned, that thread of that primary prevention running through, acting across our population, focusing on inequalities, and that secondary prevention, halting the progression of conditions, and that earlier diagnosis. And so there is, we can see that strategic alignment from that kind of regional, national and the local perspective. In terms of the Living Well programme, we have had an initial workshop with key strategic partners exploring our priorities, what we're going to focus on collectively, what are the initial scope of the programme. I've mentioned the levels of prevention that we're going to focus, and the focus on diabetes, cardiovascular disease, including stroke and respiratory. And under that, we've got 4 draft work streams that are focusing on data, and in particular how we use our data better to inform our work, how we share data, which is still an ongoing challenge, and to inform our understanding and insights and targeting, and enabling population health management approaches, and then also community involvement, which links in community champions, and then also secondary prevention for long-term conditions. In terms of what I do want to make sure that we reflect, though, is that although we haven't got a formal programme board at the moment, we're still driving this work forward. There have been some real successes already. So, part of the delivery on terms of that secondary prevention agenda, well, is the National Diabetes Prevention Programme. So it's a national programme for people that have been identified who are at high risk of diabetes, so which could be described as pre-diabetes. People can be referred via their GP, so it's important there's that early identification. And Kirklees is continually achieving the referral trajectory, which is really positive. So it's about trying to enable that access for people to access those programmes that can hopefully reverse the diabetes. So we've got a 70% of people that from that referral attending the initial appointments, which is really positive. The rate does drop to 38% for then course attendance. However, in the last 12 months, a review's found that of 38%, 38% of those who attended reversed their pre-diabetes on completing the course, which is, you know, a great result for those individuals and their families. And in terms of other work that's happening, we've been working on a CVD prevention strategy. That's just in the stage of being finalised. It's been informed by local data and intelligence, and it's going to be underpinned by an annual action plan that's going to be delivering tangible outcomes. It's going to benefit other long-term conditions work, as we've mentioned, in terms of those interdependencies, because lots of those risk factors, you know, they're common across many long-term conditions, and some of those projects have already started. So one of the pieces of work that we're already progressing is NHS health checks, which we are in public health are responsible for commissioning, that we are moving towards a targeted approach. So we're developing a new specification for that. We've also got a community champions campaign that's currently running on cardiovascular disease. We've already got some great feedback. There's been, to date, 800 one-to-one conversations with community champions about it. Lots of people didn't know what cardiovascular disease is. We've had feedback from people that didn't understand why taking their blood pressure medication was important and what the risks of not taking it were. We've had people that didn't know about NHS health checks and now saying, yeah, absolutely, now I know what they are, I'm going to engage with them. We've had fantastic support from West Yorkshire ICB. They have provided us, I think it's 15 blood pressure monitors for the area, and community champions have been trained in using those and are going out and taking people's blood pressure, and then they've had training to, depending on what the results are of what the reading is, where do they then signpost people, what advice do they give, and so, you know, that's been really empowering, and we've had great feedback from our champions about how that's enabled conversations within communities. So in terms of, and that relates to a national target that we have in terms of delivering blood pressure monitoring and people being on medication where they have higher levels of blood pressure to prevent other cardiovascular disease conditions. So the campaign that's running currently has followed on from a very successful diabetes campaign. Over 4,000 people had conversations, which is a phenomenal number of people that have had meaningful conversations about diabetes, whether it's relating to lifestyle, diabetes risks, or the condition that they already may have. And what we're getting back is fantastic information in terms of barriers to people in terms of regarding their conditions and services. In terms of challenges, I've already mentioned that we don't have a senior responsible officer, and that is a barrier to us being able to progress our programme board. We could potentially have a solution through a clinical lead, but at the moment there is a review being undertaken at West Yorkshire ICB level in terms of clinical leadership. So, you know, potentially it would be great to at least have something in the interim to enable us to make more formal progress with it. And I think it's worth highlighting that, you know, and recognising that there is reduced capacity across the system, and particularly across the ICB and also within the public health team. And there are projects that we would like to be able to progress, but at the moment, you know, there are capacity challenges as many partners are experiencing. And that, you know, the focus is quite often having to be focused on the delivery of the national programmes, and it's sometimes diverted to what's coming down from a West Yorkshire ICB in terms of long-term condition asks as well. Finally, one of the key challenges I want to highlight is the financial challenge. Key to our delivery of this programme across the spectrum are the community champions. They're really valuable as part of the work and to support the access to those prevention messages. And also the community anchors, because community anchors are, without the community anchors and their capacity and their infrastructure, we're going to struggle to have community champions. And at the moment, their funding runs out at the end of this financial year. Thank you.
Thank you for that. Are there any comments?
Sorry, there's
sorry.
a little bit more. Sorry.
Yeah.
Could you just have the next slide, please? And the next one, please. So just to introduce Nicola, who will just briefly talk to you through the Ageing Well programme.
Hello, my name is Nicola Cochrane. I'm a Transformation Programme Manager at the ICB and the Programme Manager leading on the Ageing Well. So the Ageing Well programme has been established for a while. We have Karen Jackson as SRO and we're also supported by a number of work stream leads. So the programme has been developed based on national and regional guidance and recommendations. So that's things like the long-term plan, the Yorkshire and Humber State of Ageing report and the World Health Organisation's 8 domains of healthy ageing. So we do review the programme priorities regularly, and when new guidance is published, the programme evolves to ensure that it's aiming to achieve best practice where possible. So to meet the recommendations within the publications, there's 7 work streams that have been established that are just outlined on this slide. So we've got proactive care, and that focuses on providing personalised, coordinated, multi-professional support and interventions for people living at home with frailty, and that's to help maintain their independent living and reduce the use of unplanned care. We have developed a local model in response to the national guidance, and that's been mobilised across a small number of PCNs, but work is underway to increase that delivery across Kirklees. We also had a formal application approved last year for Kirklees to become an age-friendly community, so we're now a member of the Age-Friendly Communities National Network. Engagement with communities has been undertaken to understand what older people value and what they want for themselves, and there's around 7 key themes that have emerged from that engagement. So further work's just taking place now to do some action planning against those key themes. Falls is a newly established programme within Ageing Well, so there's a system-wide workshop that's taking place in September to just start to develop what that work plan's going to look like. We have an ambition to develop a robust and resilient care sector, so that's taken a partnership approach to the development of some work stream that have got some key area of focus. There's been some engagement that's taken place with around 56 older people care homes staff with an aim of better understanding the challenges that the care sector are facing and start to look at some potential solutions to that. The outcomes are then being fed into that programme of work. We're also looking at doing a similar engagement process in the coming months with the domiciliary care sector. We have a discharge work stream, and that focuses on embedding and maturing the home first discharge approach to improve patient outcomes and improve the patient flow out of hospital. And the focus of that work stream has now widened to cover all of the discharge pathways. Virtual ward is another work stream which focuses on enabling patients who would otherwise be in hospital to receive acute care and treatment in their own home. This includes frailty and respiratory beds for patients to be discharged early from hospital or stepped up from the community to avoid admission. Lastly, we have the urgent community response, which provides urgent care within 2 hours of need to people in their own homes and to help avoid hospital admission. So UCR continues to review the service model to ensure that it makes best use of resources and have an efficient operational pathway in place. There's also strong links with key interdependent programmes, and that includes the Other Wells, mental health, housing, carers, and civic participation and employment. We have a well-established and represented programme board with membership from partners across the system, so we do have that established governance process in place. And we also have a set of high-level metrics that have been developed to monitor progress, and they're discussed monthly at the board meeting. So overall, the metrics and the dashboard showing that we're making good progress against these, with the majority of them improving month on month. Thank you.
Thank you, Nicola. And just lastly, to hand over to Michael and Sadaf to give an update on the Dying Well programme. Just move the slides on.
Thank you. Next slide, please. So I'll keep it brief. I think we just wanted to try and sort of draw out a few key points from the Dying Well update. And I suppose the first one for me is the fact that we've actually got it recognised as its own well. So that feels like a real significant sort of part of the journey that we've been on. We've also got 4 work streams that are beginning to undertake some real meaningful work. So Joe's mentioned the community champions. So the community champions will be doing a campaign around death and dying and the stigma surrounding that and the barriers to sort of accessing care and support. I think as well, the previous update around the DPH report, there's some real rich learning that's going to come out of that, and we're really keen that we continue to make sure that people's experiences inform and shape the Dying Well programme. We want to make sure that we've got all parts of the system that are involved on the Dying Well board and the work streams. I think historically there's been some gaps, so in particular primary care, but that's something that we do want to focus on. And obviously that needs to be supported by clinical and programme resource. So some of the work that's underway, just to sort of raise people's awareness, we've got a development of an integrated model of care. So that was following some of the work undertaken by Healthwatch. So one of the key themes that came from that was the support that was being offered to people that were being cared for at home. I think as well, just resting on the impact of Dying Well on the wider health and social care system. So the fact that it's a bit of a golden thread that runs through all of the other wells. And as we've had a discussion earlier, some of the previous initiatives that we've worked on, the impact of those, so things like driving and increasing the numbers of people identified as being in the last year of life, having advanced care plans. So there's lots of really great work that's happening with the Dying Well board. Michael, I don't know if there's anything that you want to add? No? Thank you.
Thank you, Sadaf. So just to bring up the last slide, which just summarises some of the questions and considerations to the board. I think it's quite evident that there's a significant amount of work that's been undertaken to deliver the connected care and support priority.
So thank you for that. There are 2 questions online for you to have a look at now. Is there anybody wanting to make a comment or add to the discussion?
Sorry, it's just the next slide on.
Oh, is there another slide?
It was that one. That one just summarises all the ones that we've...
Okay. So it's there for you to have a look at now. Rachel.
Thank you, Chair. Just to say thank you to see all that progress. There's clearly a lot going on, which is great to see. I really reinforce that community champions, community anchors approach, because I think it is absolutely where we're trying to get to with our council plan in terms of supporting the communities and making sure we're delivering things. It's one of the council plan's objectives, so clearly it's a real priority. So that's definitely an important area. I think with the SRO, it oughtn't to be a difficult one to do. So let's commit, at least between me, Richard and Carol, to try and work out who that should be. Because, you know, it feels silly that we can't just nominate somebody to be able to do that. I can't really comment on clinical leadership. Obviously, that's clearly an issue across all of them, but other colleagues may want to sort of input into that. And I guess just sort of making sure when you come back next time, I think from my perspective, it'd be really helpful to kind of see the what's changed and then what sort of practical things could the board do in terms of helping to unblock things or to deliver things that you know, just to sort of help us to be able to feel like we're contributing to it across the system would be helpful. Thank you.
Thanks, Rachel. Carol.
Thank you. Thanks for that really, really comprehensive report. I think there's probably, connected to that conversation, Rachel, a piece of work for us to do to think about what comes to Health and Wellbeing Board on these programmes and what comes to the Health and Care Partnership Place Committee. So we've already got scheduled into our quarterly Place Committee meetings updates on each of the 4 programmes, and we've already heard from Dying Well. We're talking about, and Ageing Well, talking about starting well at our meeting in August, and then I think we'll probably do Living Well in, I think it's November. So there's just something for me about thinking around who's the right group of people to ask which question of, because perhaps some of the people who come to the Place Committee might be better placed to agree some of these things that are posed here. But then again, what is the wider role for the Health and Wellbeing Board in this? So I think as we get in this new cycle of Health and Wellbeing Boards, it might just be helpful to think that through. Not least because I'm so conscious of people's time and the amount of work they have to go do to do these reports. We don't want to be duplicating either, do we?
No.
Yeah.
Thank you, Carol. Dr. Naeem.
Thank you. So obviously, fantastic work. We are now, putting, those pieces of work into categories, and I can see partnerships developing over, over our place. And I think we need to see where each one of the partners in provision of these services is placed, and where we have got gaps in service. And with this, it's becoming more clearer now that where do we need some leadership, leadership presence. I think if we see, for example, Starting Well program, and I'm just wondering, are we developing partnerships with our educational institutes, where we've got young people who tend not to attend, some of the healthcare facilities as often as we would like them to be. They've got their needs, but they're at that age where it's very difficult for them to engage with some of these activities. How we can engage them into our into our programs, whereas as it was said that Dying Well program, there needs to be some more clinical leadership. So identifying it, and then working with the ICB, working with the primary care PCNs especially, would be very important to develop and get that leadership. We are working with secondary care on healthcare pathways. Some of that work will need to be married into some of these programs. So we need to see how we can build future collaborations and partnerships. Thank you.
Thank you. Do you want to respond to that?
I was just going to add, in terms of those partnerships, I think a good example that is currently happening is in terms of the obesity pathway, and both acute trusts coming together, ICB colleagues working on it, and also colleagues from public health and the wellness service. And certainly from my side of it, it was lovely to get some great feedback from partners around the delivery of the wellness service and how they can contribute their resource that they have to support the obesity pathway.
Thank you. Can I bring in Karen Jackson?
Thank you. Yeah, I'm Karen. I'm from Locala, and I'm sorry I was late. I just wanted to do a big shout out for the people sat here who've been leading on these programmes, because they're doing a fantastic job. Because what's important, particularly I can talk about Aging Well with Nicola, is corralling all the partners and making it a partnership response. And certainly the Aging Well programming involves not just the statutory bodies, but many others as well. It's really important that we see it in the round, and the team do a great job in corralling all of that. It's not easy, but there's real progress and there's real opportunity if we work in that way. So I just wanted to call that out. Thank you.
Are there any further comments? Can I just mention that I'm absolutely with you with the community champions and the anchor organisations. They are able to reach parts of our community that nobody else will. So I actually think that is some key lines that we need to carry on supporting and investing in. Right, so that concluded? Okay. Yes, we've got the next item, the Joint Health and Wellbeing Strategy, Healthy Places. So we've got Lucy.
Me again. Could we have the slide deck, please? Thank you. I appreciate everybody is incredibly hot, so I'm going to keep it as succinct as possible with this one. So I think the first thing to say is that in the paper that I've produced with it's a very broad paper that I've produced, and what I'm sharing with you today is also very, very broad, and I think it speaks to the point earlier about one of the questions that I wanted to ask Board was what would be the most useful way for you to receive these updates. So rather than trying to tell you about everything that's happening in relation to healthy places, whether it would be more useful in the future to focus specifically on one topic area so we can really kind of get in depth with something specifically. I am definitely in this space, jack of all trades, master of none. So if there are any detailed questions you have, just give them to me and I can take them back. So next slide, please. So aims for today is just to review the Healthy Places priority. So last came a year ago, last June, to talk you through briefly some examples of success and progress within this space, and then to get your feedback on progress within your own organisations in relation to this priority, and also plan for next steps, like I've already said, potentially a bit more of a deep dive focus. Next slide, please. I'm not going to labour on this because you know this already, but this is just basically where Healthy Places sits within the health and wellbeing strategy. Next slide, please. Just to remind you of the ambition that we have for this priority is that the physical and social infrastructure and environment supports people of all ages who live, work or study in Kirklees to maximise their health opportunities and to make the healthy choice the easy choice. There are a number of success indicators related to this, which include things like overall satisfaction with the local area and use of parks and green spaces. Next slide, please. There's also the I statements. I won't read through these because you're aware of what they are, but that's essentially in the consultation phase of the strategy, getting a really good understanding of what matters to local people. Next slide, please. So just a bit more of the context. So obviously Healthy Places is a large, very large and complex priority. What is presented in the report and presentation represents a small amount of work from across the system, and it'd be useful for us to think about the theme and potential future topics for deep dives. Next slide, please. So we've already talked about community champions today, so we won't go on about this. We did invite colleagues from third sector leaders to be here as well, but sadly they couldn't be here. So Jo is just going to talk through some of the examples because, like Councillor Scott said, community champions are a great example of how we can work in our local places.
I'm not sure why Lucy said we're not going to labour it, because I absolutely love community champions, so you might have to kick me out. I am here as a substitute today. I'm here on behalf of Steffi Rogers from TSL. She leads on the programme for us and has developed and is supporting the delivery of a fantastic local programme. The model that we've got running now developed from our COVID community champions that ran for a period of time and stopped, and we were very fortunate to receive Core 20+5 monies that has enabled us for 2 years funding to really develop our Kirklees programme. Since then, we've had additional monies, substantially from the UK SPF programme in terms of levelling up, that has really enabled us to broaden the topics that we are able to, or the community champions are able to focus on. The bits that I really want to highlight are it very much is being delivered through our local VCSE. So TSL, Kirklees Third Sector Leaders, are the organisation that coordinate the programme. They coordinate the training. They're there making sure all the processes, the champions have access to all the relevant information, and so on. So, and then we have Healthwatch Kirklees that are an absolutely vital partner in this. They are analysing all the data that community champions to collect, because when they have a meaningful contact with someone, it's all entered into the tablets, and at the end of each 6 week, generally 6 week topics, it is analysed by Healthwatch. The reports that we are getting with the insights are making such a difference already in terms of informing our local system, because as well as the focus on community champions being there about improving health literacy, letting people know what's available out there, informing people about conditions, etc., and enabling that access and engagement to healthcare and wider offers. It's also very much about us getting information back from people in our communities that experience the greatest health inequalities, to understand what are the barriers for them, why are those health outcomes worse. We know some of that information, we think we know quite a bit, but actually what we're getting back from our community champions is really challenging some of what we thought we knew, and in many cases, you know, for example, language barriers for some people in our communities are much greater than we realise and much more of a barrier. And in terms of, you know, digital access, someone might have a phone, but they might not have a smartphone, or they don't know how to respond to an appointment that's an invite to secondary care between a language and a digital barrier. We have got 92 community champions working currently. They range from 18 to 65. They are working through 15 community anchor organisations. They're covering 19 languages, I should have put actually now. And then what we have, in addition to the core community champion programme, we have what they're calling community conversations. And so targeted grassroots groups, really small groups, small organisations within our communities where it's relevant to a particular topic is particularly relevant to those groups and those communities, and we really want to engage with them. They're invited to apply for a small grant. The offer is there, they can apply for a small grant, and that's enabling them to do targeted work. So they might not be, they're not signed up to deliver all the topics, but for me in my head it's a bit like tentacle reach, that we're really reaching out into communities where I couldn't have that meaningful conversation, but those groups can do. So as in terms of, I've talked about some of the funding that's come through, but by having a core offer, it also means that when there are particular topics that we would like to engage with people within our communities, and as I say, particularly people that experience the greatest health inequalities, there have been some pots of funding that has enabled targeted work. So for example, there was a winter vaccination campaign before Christmas that was using money through the COVID programme that covered access to flu and COVID vaccination. Since then, there's been work in partnership with Locala and community champions, and that's been around measles. So it then means that where they have capacity and where are those particular issues that are coming up for our communities, that we can be responsive by having that core offer. If I can move on to the next slide, please. One of the things that I really want to highlight is that community champions are from our communities. They're from within the communities. So they are people that people can relate to, they can identify with. They share potentially perspectives and can understand people's perspectives and experience. People see them as trusted people. We're getting feedback right now. Who's a trusted source of information? And community champions are coming into that. People are returning back to community champions, either for the next topic because they found the first topic they engaged with really valuable, or actually, for example, feedback has been received in terms of the mental health topic, that they might have had a conversation about mental health in general terms, and then they've gone back with something specific that then community champions have been able to give them some more information about, done some further signposting. So, you know, they are delivering in a whole range of places, which I'll come into in a bit, but it's about someone feeling, you know, it's there in their community, they're accessible, it's in places where people feel safe, comfortable, where people are. So in terms of this slide, just the wealth of community languages being spoken is phenomenal. And as I said, people are there. We have people that who have come across, who have moved to the country, including someone who's under the Afghani resettlement scheme. There are people that have been here as migrants. So again, people can relate to the types of challenges and issues that people have experienced and are experiencing. In terms of that Health Watch partnership, one of the things I did want to highlight the benefit of that is that we're having great reach. Health Watch come to lots of meetings, lots of our forums, and have great relationships with partners across Kirklees. So the insights that they're producing in the reports, they're getting out there and sharing the insights, influencing how we can shift and change and shape our system. But also they have a regional voice, and we've also had examples where, for example, related to the diabetes work, which actually we got funding from West Yorkshire ICB for, that's now produced an easy read guide in relation to diabetes, because that came back as a barrier for people, and that supports people with a range of issues, whether it's literacy issues, people with learning disabilities, where it came from, people with language barriers, and so on. They also have reached a national level, and a number of our insight reports have been shared with Health Watch England and been incorporated in Health Watch England reports that have gone to NHS England. So, for example, cervical screening for more vulnerable women. So we're having a voice that then hopefully will all filter down and benefit people in Kirklees. So the other thing that I wanted to add is just the range of impacts beyond what we've kind of set out to do. So we're improving health literacy and access, and we've got examples where practice nurses have said, we've had more people coming through for cervical screening on the back of the conversations you've had. But also, there are the added benefits. For some people, it's their first job. For some people, it's their first job in this country. And people have gone on to go and get other jobs because they've had work experience, they've built their confidence and been able to prove that they can do it. It's also improving digital literacy of the champions, but also other people that within some of the sessions that they're doing. If I can just move on to the next slide, I'll just go through it quickly, but it shows some of the types of, some of the topics that they have focused on in the last year and some of the people reached. And there are a phenomenal number of people reached, as you can see, both through individual contacts and also group contacts. More recently, there's been a women's health topic. As I've said, they're currently doing CVD, moving on to end of life. And then we're also going to focus on addictions and community safety and some more early years work. If I can just move on to the final slide for the community champions, please. This is them out and about. You might not be able to see some of the detail. They are out and about in our communities in a wide range of places. So doing ESOL classes, having an ESOL lesson focused on diabetes and then having a discussion session afterwards. GP practices are developing great relationships with a number of our GP practices. School parents' evenings doing blood pressure monitoring, community centres, supermarkets, libraries. They really go the extra mile as well. We have examples where community champions have booked health appointments for people and even attended with them when they've been nervous, or gone and had a conversation with their husband because their husband didn't necessarily know what cervical screening was. As ranges of examples of the type of things they go where they're not being asked to do that. They're doing that off their own back because they care and they're passionate and they're committed. I've already mentioned the challenges around funding, so I'm not going to go into that again. Thank you.
Okay, thanks for that. It's very comprehensive. Is there any questions? Oh, we'll see.
Sorry, I've got more. I'll be quick. So I'll be quick. Just a couple of examples, which I won't go through too much. So we are using public health intelligence to help inform our decisions that we make around alcohol licensing applications. So it's a really good way we're working. Public health and colleagues in licensing are working together to ensure we take an evidence and intelligence-based approach to decision making in local places. Next slide, please. Also got the local plan. So the local plan will set out how Kirklees should be developed over the next 15 years. And as you'll know, it will help us to decide on planning applications and other planning related decisions. Next slide, please. I'm not going to go through all of these because I sense the energy in the room is dropping. So there's just some examples of the key factors and work which is happening within Kirklees to support that. If you do have any questions, obviously talk to me at the end. Next slide, please. Again, some examples of other work which is happening across Kirklees. Next slide, please. Okay, so questions for board. How are board members supporting the delivery of Healthy Places Wellbeing Priority? And do you have any specific suggestions of how you'd like us to report Healthy Places going forward? And if there's anything specific that you would like to discuss in future meetings?
Thank you. Appreciate it. So I'll open that up. So I'll bring in Rachel first.
I know it's very warm, so I will be very quick. I just wanted to say, given, I mean, obviously there's a vast amount of work in there, which is really promising to see. And I do think the fact that we're working across multiple different directorates of the council as well as with organisations is really important. On the community anchors point and the community champions point, it's just worth highlighting that the leader has asked me to have a look at how we can take forward community anchors. And Stephen Bonnell in our policy department is doing a piece of work to map out exactly what we spend with all the different organisations and what benefits we get from anchors across the system. And I know he's been talking to a number of colleagues around the room about how we can potentially commission that in a more effective way, considering what they deliver for all of us, and how we can potentially use some of our investment into the VCSE in a better way, because I do think we tend to be a little bit of money here, a little bit of money there, and we need a bit more of a systematic approach. So I'm taking that forward on behalf of the leader, and obviously we can feed back on that and its impact on the community champions.
Thank you. Are there any further questions? No? Thank you again for that. If there's anything that you do come up with, please contact Lucy and feed into it. Okay, thank you. So I'd like to thank you for your attendance today. It's been appreciated, it's been warm, so enjoy the rest of the evening.
Yeah, thank you.